or visual 20 degrees, but the person who can plan or execute a task. So by what is the help of this functional definition is that the people who are legally labeled as blind, that is vision less than 6 by 60, are included in this functional definition because they do have some residual vision to use. Now when we go to the prevalence, it's almost, if we say look at the APDS study, it says it's 1.05%. So there are 12 million people who require low vision services, and this will increase because of increase in aging population, and the causes of visual impairment are also changing, like more ARMDs we are seeing, diabetic retinopathy we are seeing, more babies are surviving, premature babies, so they might have problem, and more neurological problems can also happen because of increase in age. But again, though the problem is there, but the uptake is very, very low. Why? Because there is lack of awareness among the service providers also and in the community also. And again we say, being an ophthalmologist, it's not that lucrative. There is no drastic quality change in life as we see in cataract as in low vision, but yes, in long term it is there. So why we focus on low vision? Because the evaluation of low vision is not as a clinical assessment we do for the routine patients. Here we are assessing the residual vision. We know now this is the residual vision, which is the remaining vision. Then we have to correlate what are the needs of the patient. Now if the patient says that I am not able to see the faces, so we have to look at that point. Then there are some patients who say they are missing. Doctor, I can read the newspaper, but when I try to read a fine print, the letters are missing. So though with my near vision glasses, I have given him N6, but still he is not happy. This you all might be encountering in your clinics. So what is the problem? So here we have to identify the means to enhance these residual functions and through a holistic approach. Now when we say a holistic approach, it consists of 4 components, that is functional low vision, which tells us what is the residual vision, how the patient is using. Then comes the clinical low vision, where we do the assessment that what is remaining and how it can be used. Then assessment and provision of low vision devices and training to use low vision device. And yes, rehabilitation is ultimate goal because we have to improve the quality of life by utilizing that residual vision. Now coming to low vision aids, there are 3 types of aids basically we can say: optical, non-optical and electronic. Optical are for distance and for near. So these are optical devices which itself says that optics are used. That is, we are using optics to improve, giving an optical magnification. And in non-optical, as the name suggests, we do not use any optical. Basically, they are assistive devices. Now, and rarely these non-optical devices are thought as prescriptive devices. And electronic, yes, with the area of digitalization in low vision also, we have a lot of electronic devices nowadays available with good outcomes, but cost is a factor. So what these devices basically do? They enlarge the retinal image so that the patient can see it with whatever target we have set in. Suppose if my patient wants 1M, like N6 size, now he is not able to read, but unaided he is able to read N36. So my target is to enlarge this image of N6 to N36. So there is again a scientific approach to do all this calculation. It's not like we go to the market, just take a magnifier and give it to it. No. Maybe in the instruction course, Rahul will explain all these things. So, but before prescribing for a successful low vision aid, we have to keep certain factors in mind. That is visual ability of the eye. That is visual acuity, refraction. Now suppose if I say that my patient requires +10, but the patient is -10. And if you don't know the refractive status, you are trying with +10, trying hard. With +10, the patient will not be able to read, because with the +10 diopter spectacle magnifier, he will never be happy. He will be happy without glasses. And again, the binocular vision, which will help us to decide combination of devices, visual field, contrast. So these are all the factors which can help us to give a successful outcome of using the low vision aid. The optical low vision aids which are there for near are spectacle magnifiers, hand magnifiers, stand magnifiers. Then there are telescopes which are available for distance, And nowadays we have this Ocutech, which is very, very good, which can focus for distance, intermediate and near. If we train the patient properly, the results are very gratifying, but cost is the factor. And then we have this low vision aid, which is widely accepted by patients for TV viewing. Electronic magnifiers, the CCTs are available from low end to high end. So one can go for, depending on the cost the patient can pay, one can go for it. So these are all handheld electronic magnifiers which enlarge the image. And this is a this is a magic computer which enlarges the image on the computer. Now again, with all the smartphones coming in, if we can tell to our patients that if they use their smartphones what they want from it, then they are very, very happy with it. Especially iPad, iPhone. There's no like, I'm not interested in all this, but I have seen very good gratifying results with all these things, because what does these devices do? They can capture the images, they can enlarge the images. So the smartphones can also be used to their maximum potential. The non-optical devices, they are rarely thought, because many times we give the low vision aid, but if the patient is having eccentric viewing or the child cannot write in a line, so these are the aids which can help them, they can guide them to use the device to its fullest potential. Other devices which can enhance the contrast are felt tip pens, increase good light, glare control devices. All the details will be taken in the instruction course, so I'm not going into detail. Like, this is a keyboard where you can just go for a larger print keyboard with a good contrast. So here you are not using any aid, but you are helping the patient to use the computer for more ease. And ultimately, we have done all this, but if we don't train the patient how to use the device, don't give them a security of vocational training or educational training, that is a rehabilitation part. And if we don't send the child back to school or a young adult back to his work, then it's of no use. Because many times the success depends, patients come and tell that I have taken this device from this market, but I don't know how to use it, or if I'm using now, what should I do with this? So the carry home message is, incorporate low vision services in your existing programs, accept barriers or opportunities, and low vision is more than testing vision and providing aids, because the aim is to maximize the residual vision to usable vision. And thank you. This is a painting which I wanted to share, because this was made by my low vision albino child whose vision is 6/60. I had been seeing him when he was 3 years old. Now he is 13 years old, so he gifted me this painting. So I wanted to share, his vision is 6/60. Thank you.